medical oncologist, Dr. James Lynam. For those of you who know Dr. Lynam, he's colourful in more ways than one. His personality, ties, and those socks. So thank you for speaking today.
Thank you. I feel really tall. All right, I think this is my third year doing this. So for those of you who've been here before, I apologize in advance that some of the slides I've repeated. I'm basing this year's talk on feedback from last year about what people wanted to hear. So mine's not quite as technical as the last one, but I'm more than happy to get into all the technicalities of it during the Q&A. Who am I? I'm a medical oncologist. I would assume that there's no one in this room who hasn't yet met a medical oncologist. Is there anyone who hasn't? No. Okay. So you all know what we do. I'm a bit like a car salesman. I try and sell you what you really don't want. And what am I selling you? Unfortunately, I deal in poisons. So I tend to call myself a professional poisoner. And it's a bit tongue-in-cheek, but unfortunately it's the truth in that most of the drugs that I give are actual poisons. And so why do I give them? I see myself as individualizing my treatment for people. My job is to try and keep my patients as well as possible for as long as possible. I do that through making decisions in conjunction with them about, how to manage them physically, chemotherapy, not for chemotherapy, observation or other drugs. Psychologically, hope versus realism in the setting of a brain cancer diagnosis. And how do I do this? I do this through understanding the evidence, as we call it. Marina put up a bunch of information about how Avastin works and didn't go into the evidence, but the Avaglio, as she said, it was a negative study in that it was, showed that it didn't do any benefit to the patients in making them live longer, but they felt dramatically better on the Avastin than they did on the water. So there's levels of evidence, and understanding that means that you can actually rationalize what you're recommending. But also, at least I try to understand the person in front of me as well when I'm trying to make these decisions. But getting back to the evidence, clinical trials. So this is the first thing I'm going to talk about, and because this is a recurring thing about what's out there, what is a clinical trial, what does it mean? We medics, we love clinical trials, and we want all our patients on a clinical trial. But what is a clinical trial? When we think about clinical trials, we think of drug trials, but there's actually lots of other things. There's trials into new imaging technologies. There's trials into new blood tests. Oh, it's not actually. I'll do this. This will go. All right. Apologies for those in the back. Obviously, my voice isn't loud enough. Trials. So not only is there just drugs, but there's imaging, new scans. There's blood tests to try and predict whether people will respond or get side effects from drugs. All these sort of things. Many of you who, after you're diagnosed, enrolled in the sequential biobank program, that is a clinical trial, and thank you for doing that, because that will help other people. But drug trials. The reality is very few drugs that look exciting when sitting on a petri dish actually ever make it into patients. Why is that? Because before we can actually put something into people, we need to make sure that it's safe and effective. Unfortunately, to get to that point, it takes a lot of time and money. This is a kind of schematic as to how many different drugs look good at the beginning on the bench on the left-hand side, and how many actually make it through towards actually getting into people. This is probably not to scale, and it's probably is even a bit worse. We think about 1 in 20 phase 1 trials will ever produce a drug that might actually get into the next phase of phase 2 or phase 3. So on Channel 7 and Channel 9, whenever they bring up the next cure for cancer and the next big thing of cancer, they're actually talking about that far left-hand side. And I love them for it, but at the same time, my patients come in the next day and say, what about this drug? And what about this? And I have to sit there and say, well, look, we've got a little bit of time yet, and we have to do the studies to try and figure this out first. So, what are the different trials? When we talk about trials, there's different phases. Now, anyone here been on a trial for drugs? Yeah, a few? Good. All right. Did you know what phase you were on? Just yell out yes or no. Phase 2? Good. 1. Good. There are different phases. Phases means that just how advanced the drug is in its development. A phase 1 trial, its role is to try and figure out, is this drug safe? We think the drug will work, but we don't know what sort of problems it's going to cause when we actually give it to somebody. So its main role is to try and figure out, is it safe? And what dose should we give? Phase 2 is to confirm it's safe at a safe dose, and then to actually see if we're actually getting a signal that says this will actually work in somebody. And then phase 3 is the large trials which says this is actually better than what we're actually doing currently. Going into a bit more detail, phase 1 studies. This is probably the largest number of trials available at the moment for patients suffering from brain tumors. So phase 1 trials. And this is a change. As of 4 years ago, people with brain tumors were automatically excluded for almost every phase 1 study. It was just, for some reason, people just didn't want to actually put people with brain tumors on these trials. That has changed dramatically over the last few years. An increasing number of trials are specifically looking for people with brain tumors, or subsets of people, subsets of brain tumors. The phase 1 trials come in 2 parts. What we call the dose escalation, which is where we actually have a drug, we just don't know what dose to give it to people. And so what they do is they get a group of people together, group of patients. We give a dose. If they have no problems and no side effects, we then get a next group, give them a higher dose. If they have no problems, we give a next group a higher dose, and on until the group starts getting problems. Now, if those problems are severe, they'll back down the dose, and then they'll decide that that's the right dose to give people. Because at the end of the day, we don't want to dramatically affect people's quality of life or indeed kill them with the drugs that we want to give. So it's all about finding the right dose to give people. The second phase of a phase 1, so phase 1B, is where we try that dose in a larger group of people. This is the main thing where a lot of the current studies are enrolling at the moment. Again, what's happening at the moment is that after we found the right dose, we would then move into phase 2, which is trying that dose in a larger group of people, all with the same condition. And this is when they start looking, well, is this drug going to do something? Does this drug have what we call a signal? Is it causing the tumors to shrink? Is it causing people to feel better? Does it look like it might be making people live longer? Phase 2 trials are actually increasingly rare because we're starting to actually use phase 1B as the phase 2. And what I mean by that is phase 1Bs used to be open to every person with every different types of tumor. Now most of the phase 1Bs are saying, I want, for example, an IDH1 mutant glioblastoma post-progression. So that's a currently enrolling trial at the moment. So they'll be very specific about the population of people who they want because they have done the tests going, okay, your cancer has this mutation, we have a drug that attacks that mutation, we need to give it into you and not someone who doesn't have the mutation because that drug's not going to work at all. So, phase 2. And then there's the phase 3. These are the largest studies, and this is where the drug's really developed. And these are the most expensive ones that trials to run, but also the ones that will really determine and change practice. Is the treatment better than what we're currently using? So when we add in whatever the trial drug is, does it work better than what we normally use? These drugs have a couple of things that can put people off. There's something called randomization. When you enroll in a trial, and there's 2 options, unfortunately, you nor the doctor get a choice as to which group you get into. It's all a magic quirk of fate. And basically your name gets put into a hat and you get assigned into a group. Now that group could be the active drug. It could be normal treatment. It could be normal treatment plus a placebo. What we tend to say is that placebo-controlled trials are not necessarily a bad thing. Placebos are only used in the setting of the standard of care. So no one should be disadvantaged by going onto a clinical trial. We are not going to undertreat anyone going onto a clinical trial. We're going to give people exactly what the current evidence says is the best treatment for them, and we're going to hope that the new drug adds on to that. So placebos sometimes are just a placebo. Usually it's placebo and another drug. All right, so how do you get onto a clinical trial? You ask. Ask your doctor. Don't just ask them once, ask them several times. Whenever you're planning your treatment, whenever the treatment plan changes, this should be one of the first questions you ask your doctor after they offer you the plan, if they haven't offered a clinical trial. Ask a support network, the BTAA, or other support networks out there. Look for yourself. There are several resources out there that can actually highlight what's going on around. These are the websites where most of the clinical trials are actually listed. The first website is a US website, which is multinational. It allows you to search internationally. The next two are local. Australian Cancer Clinical Trials has more trials listed. ClinTrial.org has less trials, but they're more focused on intervention. Most of the first two websites will bring up not just drug trials, but other trials like imaging, like supportive treatments, those sort of things, which is no bad thing, but you can end up with quite a lot of results. Does anyone want me to leave this on for any bit longer so they can keep writing? Yeah? I think the presentation will be available online anyway, so. All right. You guys can ask me. All right, I'm going to move on. Yeah. This is what the clinictrials.gov website looks like. Basically, what you do is you put in what you want to search for the trial is. You can put brain cancer. That'll give you about 4,000 results. I would recommend you try and be as specific as possible. Glioblastoma, astrocytoma, oligodendroglioma. And that'll limit things down. This is what a search looks like. So I put in glioblastoma. On the side here, you'll have some filtering, which will allow you to narrow things down. I think when I first did it, there was 800 studies. Tick recruiting, because you don't care about the studies that are closed and you can't get on. So that's one filter you need to do. And then there's another filter farther down, which is called interventional, which means drugs. Tick those filters, and that will actually allow you to kind of narrow down studies. What do you do with that information then? Look, you can look around and see where the studies are done. This tells you what the drugs are being used, what the indication is, where they're happening. As you can see, United States centric. But there is a cool feature where you can click on the top, there's a map. And if you click on the region, it'll obviously highlight the current clinical trials. And that'll go down to a state level. This website is not entirely up to date. There's several trials listed that have actually been closed for at least 8 months. But it'll give you contact details of where the trials might be running, and then you can reach out yourselves to see if it's actually still running. This is another website. This is one of the local websites, ClinTrial Refer. There's multiple different options. This one's Oncology New South Wales. There's an Oncology Queensland, Oncology WA, and Oncology South Australia. You just tick the drop down, tick on neurological and search, and that'll actually bring up what might be available within New South Wales and where they are. And there's app versions of this as well. And Victoria Cancer Trials Link is a Cancer Council funded one. Once you find a trial, the next thing is it right for you? The big hurdle is trial eligibility and exclusions. One of the things about trials is that they're looking for a specific cohort of patients. They must meet certain criteria to get onto a trial. It's not just anyone comes. There's criteria related to their diet, the type of cancer they have, to how well they are, to whether they have any other medical problems that might make giving them the trial drug a risk. At the end of the day, trials, one of the major focus of a trial is the safety of the people in front of us. if you are eligible, then you have to think about the pros and cons. Now, if people appear eligible, you'll get a long, large wad of paper, probably usually 20 to 40 pages, which goes through trials in a lot of detail, might overwhelm you. But that helps you try and make a decision as to whether it's right for you. Things to consider: potential side effects versus the possible benefit. And these are questions to ask the doctors. The fact that you're going to end up having more appointments and more tests, but you'll also end up having a lot more support from the trial staff in addition to those around the cancer care coordinators. The costs and travel involved with going, especially if the trial's, interstate, potentially international. What do I think about trials from a doctor's perspective? I like trials. And I always feel that patients should never, and people, carers, should never feel they can't ask about a clinical trial. You should never feel scared to ask about any questions, really. I treat brain tumors. I'm up to speed on the local clinical trials. I'm up to speed on most of the national clinical trials. I don't know what's happening internationally. I can't keep up to date with that. There's too much going on. So I will know what's available at this point, but that doesn't mean that you might not find something that I don't know about. When I have a patient that I'm looking after on a clinical trial, my priority is the patient. It's not the trial. If I ever worry that being on the trial is a risk to the patient and that it's not in their best interest, I always tell them this. But those are some perspectives from me. What's happening at the moment? I haven't brought up the trial information. Most of the drugs that we're actually looking at in the phase 1 setting are looking at immune therapies, different ways of boosting our immune system to attack cancer. These drugs have been in the press a lot with melanoma, lung cancer. The drugs that we're using at the moment in those types of tumors have not been that effective in brain tumors. However, we're starting to kind of mix them with other therapies like radiotherapy, like chemotherapy, to see if that boosts their effectiveness. We're also looking at targeted therapies / chemotherapy, smart chemotherapy, which will specifically target certain types of brain tumors that have a signal on them, basically what we call a heat-seeking missile. Those are the main things happening at the moment. But obviously, these sort of kind of different classes are constantly percolating and changing. Things are coming up. And that's why I haven't actually given you any specifics at this point. Marina talked briefly about what happens with drugs after the trials. After we actually show the drug's effective, we have to actually get it through various regulatory approvals, TGA, PBAC, onto the PBS. So it takes a little while for drugs to actually percolate into common use. But one of the drugs around at the moment that a lot of people ask me about, cannabis. So why do people ask me? Because it's out there. And because when you Google medicinal cannabis, you get things like this, which is great, It cures cancer without any side effects. Isn't that marvelous? Or this, a 8-year-old was cured with some oil on their dummy. And locally. I'm not saying it doesn't work, but I think this might, it affects people's perceptions as to how effective it might be. This is a printout. It hasn't been updated since December 2017, but this is produced by the TGA, which is the governing body on approving of drugs. This guidance document was produced by both clinicians, but also a very large consumer panel, so people from the community, disease sufferers, to talk about the kind of evidence and the rationale behind the use of cannabis. It's actually a really good document. I'd highly recommend if you're thinking of using it, actually looking through it. What is cannabis? Well, cannabis is actually a lot of different things. And they're basically cannabinoids. There's about 104, maybe 114, one of those two active ingredients in cannabis. And these are all different types of cannabinoids. The most commonly ones that we hear about are THC, which is responsible for why I used to use it as a kid. Don't tell anyone. I didn't inhale. but it also may reduce nausea, pain, muscle spasms. It may improve sleep and appetite. The other side is, and the most commonly other used one is CBD. It doesn't cause a high. It may help with seizures, pain, and be calming. And there's other various types of the 104 that are actually being looked at. How do you get these, how do these drugs come? You can get different concentrations of THC and CBD, and different mixtures. And it can be, you can smoke it, which is frowned upon, vaporize it, oils, tinctures, sprays, tablets, any number of different ways. How do you get it? So, at the moment in New South Wales, a doctor can prescribe this to patients. There's two ways. You can become a doctor can become a registered prescriber, which means that they've gone through various credentialing and filled out necessary paperwork to be able to prescribe it to multiple different patients. Or you can get patient-specific prescriptions, in that a patient can go to their doctor and ask for them to prescribe it, and the doctor can apply for that single eligible patient depending on whether they meet sort of specific criteria. Now, most doctors are a bit freaked out when they're asked about cannabis. There is a medical practitioner, a New South Wales Cannabis Medicines Advisory Service, where it's a phone line that both patients and doctors can actually call to get advice about how to actually rationally prescribe the drug. There's also the option of actually going on to clinical trials. There's 3 trials happening in New South Wales at the moment: childhood epilepsy, in palliative care, looking at drug levels, and also in chemotherapy-induced nausea. Those are all looking at different concentrations and different ways of actually giving the drug. Or, if any of you guys knows Dean down the road, you can get it from him. If you do, I hope there's no one named Dean. Sorry, in advance. Dino, there we go. If you do decide to use that route, I would recommend that everyone get registered on this, which is the Compassionate Use Scheme. This is basically a get-out-of-jail-free card for you and those around you. Once you're registered on this, if you do actually get caught with it by the cops, they have the option to not charge you. And I say option, excuse my French, but if you're a dickhead, they would still charge you. None of my patients who've been registered on this have been charged. You can also actually register your carers, who then can actually be involved in the supply and actually transport of it. But you have to have an incurable or terminal illness. But the definition is really kind of broad and pretty much, all my patients meet it. Most of my colleagues meet it. One things to bear in mind about cannabis, if it has THC in it and you're using it, you're not eligible to drive, if that's an option with the tumor and epilepsy. So if it's a pure CBD with no THC, you actually are allowed to drive. All right, just be mindful of that. One of the difficulties of getting it, again, from Dino is you don't necessarily know for certain what's in there. The roadside MDTs, they only pick up THC, they don't pick up CBD. All right? So you're allowed to drive with CBD only as long as you're not impaired. That's the general guidelines. Why I don't prescribe cannabis, I'm sorry, but lots of my patients ask me if I can do it. I don't. I do if it's on a clinical trial. The reason I don't is because I don't think it's met the necessary criteria for a drug yet within Australia. I think it's safe, but I don't know what side effects to look for and how to manage them. Is it effective? Certainly some of my patients feel better, but they can't tell me how sometimes. So when should I give it? And I don't know what drugs to give. There's only one drug that actually has been TGA approved. It's a tablet, which is a mixture of THC and CBD at a 1-to-1 concentration. It's approved for muscle spasms and multiple sclerosis. It's the only drug that's actually been through a placebo-controlled trial and been demonstrated to actually be effective. Most of the other placebo-controlled trials have actually not been demonstrated that it actually works that well. Does it have an anti-cancer effect? We know that brain tumors have a higher concentration of cannabinoid receptors on their surface than any other type of tumor, and than when compared to the surrounding brain tissue. What does that mean? I honestly don't know. Does stimulating that receptor, does actually giving cannabis and actually activating those receptors, does that have an anti-cancer effect? Or should we be blocking those receptors? The data is inconclusive as to whether it does anything. There's certain data out there that says, yes, it definitely helps cancer because it boosts the immune system, it's an antioxidant. There's other data that says actually what it does is it increases the speed of spread and causes it to actually move quicker. Until we actually have proper studies, I tell people to avoid it if they're thinking of taking it as an anti-cancer agent. All right. And yeah, that's the other reason. I don't know what dose to give people. All right. That was it. Thank you for being here, and happy to answer your questions later. Thank you.